You can start, doctor.
Okay. Hello, I'm Mariam and I'm ready for structured discussion.
Okay.
Yes, you can prioritize the case and tell whom you are going to delegate.
Okay, thank you for the question. Actually, I received the handover at 8:30 a.m. and I'm well aware of my team, which is present with me, and I will introduce myself with them. I need to know that my access to the theater and obstetric theater is available or not, and cots they are present or not. I will have a panoramic view on whole of the board, and then I will assess the competency of my team. And if you allow, then should I go room to room?
Yeah, that's up to you, doctor. That's fine.
Okay. By looking on this board, the room number 356, they seems to be urgent, but my priority might change when I ask for extra information. So coming to the room number 1, here the patient undiagnosed breech in labor. So I need information that what are the perabdomen pervaginal findings, CTG has been initiated or any additional risk factor.
Yes, means all observations are normal. She is a low risk, except for the fact that it is an undiagnosed breach and perabdominally same and I means breach and PV 9 centimeter. She went into spontaneous labor.
Okay, so this is the semi-urgent case. I will allocate it to the midwife, and I will ask her to review the any scan finding available.
Any ultrasound?
Yeah, scan
Yes.
finding available.
Yes,
Estimated fetal
it
weight.
is a foot-link breach. It is a foot-link breach with estimated fetal weight of 2.5 kg.
Okay, so now this is the urgent case. I will go by myself, and I will ask the midwife to pass the IV line and take the blood for group and save. And urgently, I will ask her to inform my consultant to come and attend urgently. And I will be having a panoramic view on the rest of the ward and preparing this patient for category 1 cesarean section and giving her the cover of steroid. Initiating the incident reporting as well. Room number 2, here the patient primary 32-week with decreased fetal movement. So I need to know what are her vitals, any PAPV finding, and Doppler finding and scan finding available or not, or any additional risk factor.
Yes, the patient's blood pressure, pulse, observations are normal. She is complaining of reduced fetal movement. Fetal heart sound is here on auscultation. CTG is ongoing.
Okay, so this is seems
Otherwise,
to
low
be
risk.
the
Otherwise, low risk.
The FHR is good for
okay.
room
So
number
this is
2.
the sorry.
Fetal heart rate is good for room number 2.
Okay, so this is the non-urgent case. I will allocate it to the midwife and taking her complete history to exclude all the risk factor for stillbirth. And once her CTG is normal, then reassuring her and asking her to come back and telling her red flag if she again experiences such type of the fetal movement. And room number 3, here the patient 29-week monochorionic amniotic in labor. So again, I need to know per abdomen, per vaginal finding, cot is available or not, and any additional risk factor, CTG initiated or not, and vitals.
Yes, the patient's observations are normal. Per abdomen, she is contracting 3 contractions over 10 minutes and PV per vaginal, she went into labor 5 centimeter. Both the twins CTG is normal. Cots are available. Patient is on epidural. And on ultrasound, both are cephalic.
Okay, so this is the semi-urgent case, and I will allocate it to the ST2 after ensuring her competency and monitoring her for normal progress of labor, but passing the IV line, taking group and save, and be aware of the PPH and making sure that pediatrician they are available at the time of the delivery and active management of third stage of the labor. Room number 4, here the patient primary 41-week high head. So here again, I need any additional risk factor, estimated fetal weight of the baby, and per abdomen, per vaginal finding, any per speculum finding.
Yes, her observations are normal. On a 20-week anomaly scan shows low-lying placenta. Otherwise, per abdomen is normal. PV, the patient is having a poor Bishop score.
Poor Bishop score.
Yes, it is a Bishop score of 2.
Mm-hmm. So this seems to be the say high urgent and high priority case because the patient is having low-lying placenta.
No,
And
low-lying placenta 20 weeks anomaly scan. It is a
okay.
20-week anomaly scan. It is a low-lying placenta. Now patient has been planned for induction of labor.
Induction. Okay. So here this is the non-urgent case because induction has not been started yet, and I will allocate it to the midwife to take the full assessment and doing the scan and assessing the estimated fetal weight and start her induction. Room number 5 here the patient again previous 3 scar with minimal show. So is she in a labor? What are the PAPV findings? CTG? Any additional risk factor?
Her observations are otherwise normal, but per abdomen she is contracting 3 to 4 in 10 minutes, and PV is 3 centimeter, and on CTG it is showing fetal tachycardia of 174 beats per minute.
Okay, this is the urgent case here. I will ask another consultant to come and attend it and having panoramic view on the rest of the board and asking midwife as well to go and passing the IV line and taking the group for blood for group and save and preparing this patient for the category 1 cesarean section, making sure that blood and all the arrangements they are there and consent for the blood transfusion and even hysterectomy has been taken. And room number 6 here, the patient at preterm with the leaking. So need her vitals and PAPV finding, per speculum finding, and what is the presentation of the baby on the scan, any additional risk factor.
Yes, she had a spontaneous rupture of membranes, and per abdomen is she's on observations. She's having fever and maternal tachycardia, and per abdomen is tender. PV is leaking, and on CTG it is fetal tachycardia as well. And she on investigation she is showing high CRP.
And presentation on the scan?
It's cephalic.
Okay, so again, this is the urgent case. I will ask another ST5 from the ward to come, having panoramic view on the rest of the board and informing the consultant as well, and asking the midwife to take the to pass the IV line and taking the blood and giving the steroid and the magnesium sulfate. After once she is stabilized, then planning to expedite that delivery. Room number 7 here, the patient has delivered but she is von Willebrand, and I need to know, is she bleeding right now? What is the bleeding status and vital finding?
Yes, she has delivered half an hour back, no active bleeding. Otherwise, the patient is stable. Oxytocin has been started. She is a case of previous PPH. Now there is no active bleeding.
Okay, but will be the semi-urgent case, keeping her risk factor of previous PPH because there is risk that she might bleed again in the postpartum period. So we will be continuing the transamine for further 2 to 3 weeks, and we being very vigilant for the secondary PPH. And I will be allocating that to the ST2 after ensuring her competency. And room number 8 here, the patient waiting for epidural. So I need to know what are her PAPV finding and is she in labor and CTG, any additional risk factor?
No risk factor. She is a low risk previous to vaginal delivery. Otherwise, the patient is a stable patient.
Is she in labor?
Yes, she is in labor. She wants epidural. She is 1 to 2 centimeter dilated.
Okay, so this is the semi-urgent case. I will allocate it to the ST5 and status along with the midwife to discuss with her the option of the pain management and especially the epidural. Room number 9 here, she is GDM patient and she is induced by. So here I need to know.
It is a
Sorry, what is
dinoprostone
that?
gel. It is a dinoprostone gel, doctor.
Okay, so I need to know what are her PAPV finding and what are the CTG finding, any additional risk factor, estimated fetal weight of the baby, and what is the weight of the previous baby.
Yes, the previous baby is weight was 3 kgs, and the estimated weight of the present baby is also 3.2 kg. Per abdomen, she is contracting 3 to 4 contractions over 10 minutes, and currently she is 2 to 3 centimeter dilated.
Time up. Time up.
Okay, so this is again semi-urgent, and I will allocate. Should I continue?
Finish
No,
it off. Continue and finish it off, but 10 minutes is over.
Okay, so this is the semi-urgent case, allocating the midwife to monitor the progress of the labor and passing the IV line, be aware of the PPH, keeping her previous history and GDM, and actively managing the third stage of the labor. So overall, looking at this board, room number 1, room number 5, and room number 3 and room number 6, they are urgent, but the room number, the one which is with the choriomyelitis, that will be my top priority, followed by the room number 1.
Okay.
Thank you.
okay. What's your thoughts?
Question. Like you have told that you'll be sending one consultant to room number 1 and another consultant to room number 5 and another
Yes.
ST5 to room number 6. Is it your final prioritization?
So I went ST5 went to the room number 1, and one consultant in the room number 5, and another in the room number 6.
So you have
Only one.
another extra consultant.
Yes, I will ask other consultant from the ward or from the clinic.
Okay. Okay. So what's your own reflection on this? So it was a very good attempt. Like you have almost tried to finish 9 boards in 10 minutes. And you tried to cover almost 75% of the points. So it was a very good attempt. So what is your own reflection? What you felt went wrong and what went good?
My own reflection is that Dr. Lakshmi, I did very bad.
Hey, no. You did wonderfully. Don't see. You have to learn from the mistakes, but don't means think like you are not doing properly.
So it was an overall very good attempt. As I've told you, you have covered almost all the points which we were expecting from that. So always remember, like in my previous labor ward discussion, when if you have attended, I told you a simple tricks to how to approach the labor ward. So when you are presenting, where if you have cut shorted your introduction a little, you must have had time to complete your 9th station and also to summarize at the end. Because your introduction took around 1 minute and you were repeating few things like that the panoramic view was almost repeated 3 to 4 times in that entire 10 minutes. So you can minimize the introduction because no matter how long you talk about the introduction, it is not going to give you any marks. They're just going to see whether you're situationally aware or not. Hi, I'm Dr. Lakshmi, one of the exam candidates. I'm ready for structured discussion. I've taken the labor ward handover at 8:30 a.m. and have my efficient team with me. I'm going to go room wise or I'm going to attend the urgent rooms first. That's all. This will take you maximum 30 seconds of time.
Dr. Lakshmi, in the start, what you told, consultant is present with you. This thing makes me confused. And then consultant was not mentioned. Where is consultant?
If the consultant is not in the particular scenario, they'll definitely give you the consultant is away or consultant is 30 minutes or consultant is occupied in one theater, they will mention. If nothing specific.
But here nothing was.
Yeah, nothing was specifically mentioned, which means consultant is available. Okay.
Consultant is available.
Yeah,
If nothing is mentioned, it's mean available.
Yeah, it is available. If the consultant is not there, they'll definitely mention this. Where is the consultant? Okay. So keep your introduction statements as short as possible so that you'll save time. So that is one major thing, because if you have minimized it, you would have time to complete your 9th station well within time. And don't ask the examiner whether you want to go room wise or urgent. It is up to you. But you have to inform the examiner in the beginning that how you are going, so that they'll help you with the details or the observation or the questions which you are asking. I'll be going room wise, or I'll be attending the urgent rooms first, then I'll go room wise. Tell something like that. You decide and you tell to the examiner. Is that clear, Doctor?
Dr. Lakshmi, some mentors, they are saying that always ask from examiner, because examiner to examiner this varies. Like some prefer to go first to the urgent and some prefer to go room by room. That's why I ask what are your preferences.
See, it depends upon the examiner that you are getting, and in the 10 minutes time, you have to cover the labor board. If you are comfortable in going room wise, you go room wise. If you are comfortable in doing urgency wise, do urgency wise. Don't get confused with examiners. Like if the examiner is saying like you go by urgency wise, but you had been practicing in the room wise, then it will be very difficult for you to do that in the exam.
Yes.
Is it making sense, Dr. Mariam? Because if you're whatever you are comfortable, you have to finish the board. The 10 minutes is yours. You are going to be the king of the 10 minutes. So try to finish in the 10 minutes and try to make use of the 10 minutes in an efficient way. Always
Mm-hmm.
going room wise won't confuse the examiner, but if you think the last case might be an urgent case, then you can go urgency wise. Otherwise, if you are very confident enough in finishing a room wise, you can go by room wise, because it won't confuse the examiner by saying the findings. Got it?
Okay. Okay.
But if you think the last case is going to be an urgent case, like if they are telling BP is 200 and 110, the patient is having headache, an antenatal patient, then obviously the ninth case, if you think that you are not able to finish, then it's always better and brilliant to finish the urgency case and then to go room wise.
And if at all, first when you're in that 2 minutes, try to go whatever information given in the task and also try to put your concentration on the last 3 rooms of the board. Sometimes there can be 11 rooms also. Then even in the 2 minutes, you might not have time to go through all the 11 rooms. So start from the end. You see if there are any urgent rooms in the last 3, 4 rooms. If there is any urgent room, it is a better idea to attend the urgent rooms first, because if you don't speak about urgent room in your 10 minutes time, it is highly not possible to clear the labor ward. You will be either getting borderline or sometimes even fail. It depends on the examiner. Okay, if you're comfortable with room wise, you go room wise, but make sure there are no urgent rooms in the last 3 or 4 rooms. Is that clear, Dr. Mariam?
Yes, yes.
Okay. And coming to the feedback, so labor ward, there will be lot of information because we keep talking something. There will be some set of information for the examiner, and they have to mark according to the information they are having. So what is important is be crisp and clear about what we are talking and what information you want to get. Don't ask about pulse and blood pressure for each and every question. No need to ask about it. For example, here a patient has come for induction of labor. Of course, it is not going to affect your mask even if you ask about observations for that patient. But what do you have to know for a patient on induction of labor? Whether she is having any risk factors, whether the CTG is fine. That alone is sufficient, right? We don't have to worry about the observations. So be specific about what questions we are asking so that we'll be it will be good for the examiner also. So I'll be going room wise for your feedback. So in the first room, yes, and moreover, one good thing is you have prioritized all the rooms very well. Your prioritization and assigning of the team is absolutely perfect. And coming to room number 1, yes, you have identified it is an undiagnosed breach in labor. No matter if it is a footling or normal breach also, any undiagnosed breach in labor becomes an urgent scenario. You have identified it as an urgent scenario, and you also asked about any estimated fetal weight and where any scan has been done to the baby. That is a good habit. So always first ask questions, whatever questions you want to ask. Talk about the risks and the ways to minimize the risks, and about MDT. These are the 4 things which you have to apply for each and every room. Just these 4 things. No need to talk more than that. So how would I do this room number 1? So this is a undiagnosed breach in labor. I would like to know the observations, per abdomen, per vaginal findings, whether any any contraindications for the normal delivery of the breech, estimated fetal weight. Then this is at the risk of breathing difficult, fetal distress, and birth injuries. So the recommended mode is LSCS. I would like to counsel the patient for the options of delivery. If she agrees for the LSCS, I will ask my ST2 to take the consent, and I'll ask my midwife to make the patient ready for the cesarean section. In the team of doctors, I'll alert the theater team, I'll inform my consultant regarding this particular patient, and also I'll inform the neonatologist and the anesthetist. So this is an urgent room. I'll be doing the section myself. Is this clear, Dr. Mariam?
And also, Dr. Mariam, you
Uh,
told it was a category 1 cesarean section. I don't think
yes,
we
like it
recommend.
will be category 1.
No, no, no,
Hmm.
no. Because uterine rupture or abruption, cord prolapse, these will come in category 1 because category 1 has to be done in within 30 minutes.
No,
Okay.
she is also at risk of cord prolapse, like 9 cm you told
See,
then.
yes, 9 cm, but you think category 1 cesarean section within half an hour to make a patient ready in NHS will be very difficult here. So it's not quite possible. So for category 1, it will be like there are few specific means indications like scar rupture, abruption, cord prolapse. She is at risk of cord prolapse, but she is not having a cord prolapse. No, anyhow, you are going to prepare and you are making her ready.
Should I mention the category of section or not?
It's
Absolutely.
better in this case. It's not ideal to mention as category 1 because if it's an VBAC patient with pain and pain abdomen, fetal tachycardia, if you're suspecting scar rupture, you can mention category 1. If you're suspecting a cord prolapse, then you can mention a category 1. If there is a prolonged deceleration for more than means for more than minimum of 3 minutes, then you can mention like any abruption you can mention.
We'll
I
share
don't
the,
think
like
in this
categories of
case.
cesarean section. So only those who fit into category 1 cesarean section you can tell. Not you can talk about other what is the category of cesarean section you have to mention, but it might not fit into category 1 cesarean section, room number 1.
Yes.
So if you're in doubt like which category it fits and you don't know what exactly it is going to fit, don't mention the category. Okay, it's better to stay without telling any category rather than uttering a wrong one. Okay. So coming to the feedback, you spoke about Dr. Priti, do you want to talk about anything?
No, this is what I want to mention. The other things she didn't.
Okay. So regarding the information you asked about the pervaginal, parabdominal, and the CTG findings, you categorized it as an urgent. And you also spoke about the consent, IV line group and save. And also you asked about estimated fetal weight of the baby. So this station was good. But what I was trying to tell is be more structured so that it will be easy for the examiner and also easy for you to complete within time. And
And Dr. Lakshmi, you
yeah,
see, sorry to interrupt.
no problem.
Like you see, when you told that it is a footling, then I told that it is urgent. If it was not footling and it was undiagnosed breach in just 2 to 3 or 4 centimeter, still undiagnosed breach in labor was urgent.
No, it will be a
3 to 4
semi-urgent.
centimeters, it will be semi-urgent. But if it is 9
Mm.
centimeters, you can categorize an urgent case.
Okay.
If it is an early labor. And also, whenever you see undiagnosed breach, say incident reporting. Okay?
So I told this.
Yeah, she mentioned incident reporting.
Okay. Then room number 2, like it is a patient of decreased perception of fetal movements. So whenever you see decreased fetal perception of movements, only two things you can ask. How is the FHR now? And is this a first episode or the recurrent episode? Only these two questions are important. Because if it's a first episode and the FHR is good, it becomes a routine case. But if it is a recurrent episode, you may have to do a USG with Doppler and you may even have to admit her and put a CTG. So these are the two questions which help you to categorize the second room number. You asked about the risk factors of USG. That is good, but before that, better to ask the two questions which I have told you. Your prioritization was good. You have prioritized it as non-urgent and you assigned a midwife for it. It was good. And you also reassured her. You have told about the red flag signs. You asked about the information gathering regarding the risk factors. So room number 2, you did well. But remember these two questions so that it will become easy for you. Room number 3. Room number 3 is a twin in labor. So what are the two things which you need to ask when you see a twin station in the labor board? Dr. Mariam?
Presentation of the cephalic
Yes.
and cots there. Sorry, presentation of the leading one and the cots available or not?
Yeah.
Yes, you do ask that.
Yeah. Presentation, Dr. Mariam, I don't think you have asked, but Dr. Preeti has told herself that
I asked.
No,
I
I
asked.
myself told before she asked. It is
Yeah.
not her problem. I told before she asked.
Because as far as I remember, she asked about PA and PV, and then Dr. Preeti has told about all the findings in one go. Maybe she might have revealed before you asked. So remember to ask about presentation, and if they didn't give the gestational age is important, and also any complications in the twins. That question you need to ask because MCDA twins are at risk of complications. So any particular complications in twins. Okay? And
Okay.
prioritization was good. You prioritized as a semi-urgent and you assigned an ST2. Even you can ask a midwife to go and see the patient. And when you see this room, what you have to say? So I would like to know the presentation of the twins and about the complications. These twins at the risk of preterm delivery and PPH. So to minimize the preterm delivery, talk about steroids, magnesium sulfate, and tocolytics if needed, if it is an early labor. And to minimize the PPH after delivery, in case if it progresses and deliveries, I'll give active management of third stage of labor. And in the MDT, I'll involve the neonatologist and I'll make sure NICU bed is available. Is this clear, Dr. Mariam?
Yes, and this was 5 centimeter. It will be urgent or semi-urgent?
You can categorize it as a semi-urgent case.
See, urgency, semi-urgency, if you're able to substantiate, even you can say this case as an urgent, and if you're able to substantiate, that is well and good. They are not going to reduce marks if you are categorizing a semi-urgent case as an urgent, like that. Okay, but you should not miss a gross things like an 9 centimeter footling breach. You should not miss it its urgency, and then 3 previous cesarean section in labor, that you cannot miss a PPROM.
What about substantiation? Like, how do
Yeah,
you substantiate the particular case? Why you are feeling it as urgent? Why you are feeling it as a semi-urgent? Sometimes some cases might look routine for you. They might be a routine case, but you might feel it is a semi-urgent case. Then substantiate why you are feeling it as semi-urgent. Once you substantiate, that is well and good. They don't cut your marks when you say a routine case as a semi-urgent, as long as you are covering all the 5 domains which they are looking for. But important thing is none of the urgent case has to be missed.
missed.
Is it clear? So always talk about
Yes.
what questions you need to ask and be specific about the questions. Next, at risk of so and so. To minimize this risks, I'll do this. This has to come to your mind. Like you have to practice and practice so that you'll follow this particular order. And yeah, rule number 4, induction of 41 weeks with high head for induction of labor. So what are the 2 questions you should know about this patient?
Estimated fetal weight and liker.
Yes, absolutely. So high head. So it might be a big baby or a floating baby. So you need to ask about those 2 questions. Ask about them specifically. You asked about per speculum examination also. So what is the need of per speculum examination here? Not necessary.
Might be she is
Hard collapse.
There is no leak. They didn't mention anything about the leak.
Okay, okay.
Cord prolapse occurs at the labor. So I would like to know about the estimated fetal weight and liker, any risk factors. If you ask any risk factors, she might have told you about the placenta at 20
No,
weeks.
no, I told about the placenta.
Yeah, yeah.
But actually, in this case, you have to say you will check the scan at whether the rescan
32
is done at
can be
32
done.
and 36 weeks for the placenta localization. That is also very important, because I do mention like she had an low lying placenta at 20 weeks on the rescan.
Okay.
You remember, Dr. Mariam?
Yes.
yes.
So ask whether if I would check whether any repeat scan has been done. This patient is at the risk of cephalopelvic disproportions, prolonged deliveries, and cord prolapse. So what are the steps you are going?
Control ARM we are doing in this
Yeah.
case, if needed.
Yes, at the minimizing risk, you can tell. So at the risk of PPH, cord prolapse, prolonged labor. So what precautions you are going to take? I'll plot a WHO labor care guide. CTG monitoring will be done. And in labor, controlled ARM will be done. After delivery, active management of third stage will be done. I'll ask my midwife to monitor the patient, and if there are any concerns, I'll ask her to inform me. Okay?
Should I mention that if on a repeat scan, if it's still low lying, then the mode of delivery might change?
Yeah, you can mention. I'll check the repeat scan if the placenta has moved up or not, and the mode of delivery depends upon the placental position. You can mention. Okay, so give some pauses when you are telling. Don't talk in long sentences. So, Dr. Mariam, I was very much happy with your presentation. So I'm giving the feedback as an overall feedback so that it will be helpful for rest of the people also. Okay.
Okay.
So the room number 4 was good. And in the room number 5, you have identified it as an urgent case. You asked about the PA, PV, CTG. All those were good. You categorized it as an urgent. You involved the consultant. And you spoke about the category of cesarean section. You spoke about consent, IV line, grouping, and saving. All those things were good. Whenever you see a previous LSCS in the labor board, so what questions you need to ask specifically, apart from ones you have asked?
Any complication after that surgery, any specific recommendation? I will review the notes.
Pulse rate. Instead of observations, when you see previous LSCS, say pulse rate. I would like to know about the pulse rate, contractions, pervaginal findings, and the color of urine. Remember the patient from head to toe. Whenever you're asking about these questions, always remember a pregnant lady from head to toe. Come from toe to bottom so that you won't fish. What will come from up, head to toe? Talk about pulse rate. Then in the abdomen, you have to see the contractions and the CTG. Pervaginal findings. And there will be a catheter bag in case if it is, assume like there is a catheter bag. And what about the urine color? These are specific for previous LSCS because you are ruling out scar rupture. Am I right?
Okay.
So ask
It's not about catheter bag. You can just mention
the
how about the urine. No need to.
catheter, not the catheter bag. I just told so that we can remember it. Catheter bag
Yeah.
will be at the end, right? So you can look at the color of the urine. Okay. And tell this patient is at the risk of scar rupture. Okay, Dr. Mariam. So I think you didn't mention about the scar rupture. So talk about the anticipated risk. Now, how you are going to minimize the risk? I'm going to take her for immediate cesarean section. And here, my consultant will be doing the section as it is a previous 3 LSCS because there can be a lot of additions with that, right? There can be chances of bowel and bladder injury. So it is better your consultant does the surgery. Okay? I'll take the...
And I told that consent for transfusion and hysterectomy as well.
Yeah,
Yes.
that was highlighted. Yes, you spoke about the consent. You spoke about reservation of blood. All those things were well covered. Okay, and you can also involve the theatre team. I'll alert the theatre team. I'll inform the anesthetist and the pediatrician. Okay? Even if you don't mention the pediatrician, remember the theatre team and anesthetist for a section. Now, room number 6. Yes, it is a teenage primey with history of leak and fever. So what is your diagnosis?
Choriomenitis.
Oh, okay. You have to utter that word. So you asked about the PA, PV presentations of the baby. That was very good. You asked about the risk factors. The questions were good. You can also ask when your role play when Dr. Piti was telling that she was having fever, contractions. I would like to know if there is any foul smelling leak. You can also ask like
No,
that.
she did ask about PV as well.
PV she has asked leak color of smell also you can ask, but it is not an asterisk point. So and here
I didn't address teenage. I forget. I didn't address the teen. I think will it be marked?
Yeah. This is the point of giving the teenager. So what are the 2 things which you need to when you see a teenager in the labor board? Anyone can answer.
Safeguarding issue any?
Yes. And one more?
Safeguarding issue and another child, any adoption like that.
Yeah. Decision regarding the baby. So this is a primey with suspected chorioamnionitis. I would like to know the pulse observations, pulse rate, blood pressure, CTG, if there is any foul smelling like whether any safeguarding issues were involved and decision regarding the baby. Now, what is in the treatment part and the MDT, what are the 2 things which you need to remember for a chorioamnionitis?
This is urgent case of the high priority.
Okay, yeah, she prioritized it well as an urgent and she has involved an ST5. Specific for chorioamnitis. So when you see a chorioamnitis station in the labor board, what are the few things?
Sepsis 6 care bundle you have to start.
Yes. And Sepsis care bundle, you can say, because they keep changing those components. You can say sepsis bundle.
Okay.
Okay. So whenever you say chorioamnionitis, it is a suspected case of chorioamnionitis at risk of sepsis. So I'll immediately initiate sepsis care bundle. Take the investigations, which include, so CRP has already been mentioned, serum lactate and blood cultures and other blood investigations like CBC, LFT. I will start her on IV antibiotics after ruling out allergies.
That's
I'll involve my consultant, microbiologist also. You need to take the name of microbiologist. And as it is a preterm, involve the neonatologist as well. Okay, Dr. Mariam?
And steroids
Yes.
controversial, doctor. It will be
Yeah.
you tell if you are mentioning steroids in a chorioamnitis, always involve the consultant and neonatologist because it can flare up the sepsis. So you have to keep them in the loop as well. That will be the wiser decision. If at all in a chorioamnitis you are mentioning sepsis. Sorry, steroids.
Steroids will be considered after discussing with consultant and neurologist. You can say like that. Because in chorioamnitis, we have a lot to talk about even before steroids. Okay, investigations, treatment, sepsis bundle, involve the microbiologist, and also, we have to deliver the baby. If the patient is in chorioamnitis, settle the patient and deliver the baby.
NSU cart availability.
Yeah. Whenever you see preterm, neonatologist and NIC cot availability. Is it clear for everyone? Till
Yes.
now? Any other doubts till now? Okay. Room number 7. So you have identified as a semi-urgent case. You asked about bleeding. That was very good. That is the one important question you have to ask. And you spoke about tranexamic acid also. So what are the things you feel that you might have missed, Dr. Mariam? I know you know about von Willebrand, but you might have missed it because of the time.
Yeah, this desmopressin response.
I told you she has delivered half an hour back. Then what you will mention? You have just delivered baby
It's a
half an hour back.
delivery, post
Yes.
delivery, and
The baby checking, baby checked.
yeah,
Yes.
what spot for the baby. So recent factor level becomes important in an antenatal patient, and if the patient is having bleeding, we need to check about what are her factor levels, whether factor replacement is needed, Dr. Bhuvi. But as in this particular scenario, there is no active bleeding. So what can we talk about here? So whenever you see post-delivery patient, you need to ask whether there is any bleeding that you have asked Dr. Mariam, and whether the placenta has been delivered, Amstel has been given or not. As is a von Willebrand, you can also ask whether traffic has been started or not. Is it clear?
What have been started or not?
Tranexamic acid, that you have told.
Okay.
That you mentioned, even the delayed PPH, because these are the patients who are at risk of and delayed PPH because of von Willebrand. So that you mentioned, it will be given for 1 to 2 weeks. Those things were good, but baby part is missed, dear. Now I've given a clue. Tell me.
So
Sorry.
what about baby?
Okay, and
Baby
semi-urgent
ultrasound.
was
Even before baby ultrasound, immediate thing what you are going to do. You delivered a von Willebrand baby. Now,
we will first stabilize the patient, looking the patient is she bleeding or not,
Baby is not
giving her
No,
tranquilizing.
baby.
bleeding.
baby.
Patient is not bleeding, I'm telling. No. For baby, what injection you will give soon after the birth?
Vitamin K. Vitamin K.
Orally. We will give oral now.
That will be given orally, not
Yeah.
IM injection.
So avoid IM injection. So firstly, for baby, you need to tell baby, I'll inform the neonatologist regarding the baby. Avoid IM injections. Oral vitamin K will be given to the baby. And if needed, you can talk about ultrasound. Ultrasound comes later on. Firstly, you need to avoid IM injections. Alert the neonatologist, avoid IM injections.
Okay.
And cranial ultrasound, you can remember. You can tell if you have time.
Okay.
And in the post-delivery,
Okay, but cranial, Dr. Lakshmi, cranial ultrasound will be in type 3, I think, not in type 1.
And if the patient is having any bleeding or any hematoma, then only we'll be doing. I mean, the baby is having any of these symptoms, then only we'll be doing, or in a severe cases we'll be doing, not in.
Yeah.
So that's why if you have
Okay.
time, you can talk about it. But important is oral vitamin K and avoiding IM injections. Not
Okay,
only,
and that will be semi-urgent.
yes, semi-urgent because she's not having bleeding. Any serious case which has settled comes under semi-urgent. For example, it is a preeclampsia, but now her BP is controlled. It becomes a semi-urgent case. Okay, you have
Okay.
prioritized it well. And traffic is usually given for 3 to 5 days, depending upon the mode of delivery. And in the MDT, here you need to involve the hematologist as well, neonatologist and hematologist. So how it goes? Here, for example, for room number 7, you can say, I would like to know whether the placenta has been delivered. Is there any bleeding or an active management has been done or not? And also any complications for the baby. This von Willebrand disease is at the risk of PPH and also bleeding into the baby's brain. So I would start her on tranexamic acid if not done earlier. And for the baby, I'll involve the neonatologist and the hematologist will also be kept in loop. I will ask so our IM injections will be avoided for the baby and will be giving oral vitamin K. Is it clear? So I have involved
Yes.
eating. I spoke about the baby. I spoke about the mother. And I also spoke about what risk the patient is at. Right? So go in an order. Try to brainstorm your brain in such a way that you'll go in an order for whatever board you see. And you should be well aware that what questions I need to ask if I see this particular patient. Because if you can see their previous recalls in labor ward, they'll be repeating these things only. One form or the other, they keep repeating the same things. So room number 8, is it clear for everyone?
7. Clear.
So room number 8, you asked about, you have prioritized it well. You assigned an anesthetist and you asked about the CTG. Sorry, CTG, I think you didn't ask. You asked about the labor details, whether she's in active labor or not, she's in labor, you have asked. Your prioritization was correct. So when you see an epidural patient coming for epidural, so what is this patient at risk of?
Prolonged labor,
And
increased risk of cesarean section.
prolonged labor and need for instrumental deliveries. These patients are at risk of prolonged deliveries and need for instrumental deliveries. So I'll ask my anesthetist to look into the patient, get proper consent, rule out any contraindications for epidural. After giving epidural, CTG monitoring will be done for at least half an hour. Okay? So I have involved the MDT, I have involved my colleague anesthetist. I spoke about the risks and how to minimize those risks I spoke about. We can do labor care light plotting and also we'll do a CTG. Is that clear, Dr. Maria?
Yes, yes, very clear. These two things that were not in my mind, the prolonged labor and risk of instrumental delivery.
Yeah.
And putting for half hour on a CTG. Thank you.
And room number 9. So this patient is at GDM. You have very well prioritized it well. And you also asked about previous estimated fetal weight now and also about the previous estimated fetal weight. Also remember to ask about any complications in the previous delivery. Because she's a second gravida, she might have any shoulder dystocia in the past delivery. Ask any complications in the previous delivery. Okay, that is also an important question. And also you should be aware of the recent blood sugars and the HbA1c levels. Okay. Whenever you see diabetic patient in the board, say this patient is at the risk of shoulder dystocia or a PPH can occur because the baby might be huge, right? So how do you minimize these risks? I'll involve the diabetologist, monitor the sugars, labor care gate plotting will be done. Post-delivery active management will be done. Is that clear?
Yes, yes.
If you see me, I'm not using any sentences. I'm talking word and only words. I'm talking as if I'm putting a comma. I'm not using sentences anywhere. So if you do like that, it will be more catchy for the examiner. They can understand your points because they'll have a particular checklist where they'll be looking up the points which you are telling. So it will be easy for them to mark and they won't miss whatever you have told. Okay. Dr. Mariam, you have cleared the station because you have covered all the urgent rooms, your prioritization was good, and your assigning of the jobs was good, and you have covered all the important things in each particular thing. I was just telling these few things so that it will be even better.
Thank you so much, Dr. Lakshmi. What will be the overall prioritization? It was
Yes.
overall prioritization of mine was how you grade that?
Yes, your overall prioritization was good. You classified room number 1 and room number 5, the previous 3 LSCS, and room number 6 as urgent. Here you can go ST5 can go and do a section of the undiagnosed breach. And your consultant will be doing this previous 3 LSCS section. And what about room number 6? What is the immediate management for room number 6? This is an urgent case. So you are going to start her on antibiotics and take investigations. So senior midwife can do that.
Highest priority among all of these, highest priority among all of these will be room number 5 or room number 6?
So highest priority will be room number 6 because she is at the risk of sepsis.
But she is not, see, among all the rooms, the room number 1 and 5, they have to go. Like room number 1, she is a footling breach, ST5 will be going. Room number 5, it is at the risk of scar rupture, the consultant will be going. Room number 6, we can allocate a senior midwife.
6 needs stabilization,
Yes, first initial stabilization, and then whoever is finishing then can come. Or you have told very well that the consultant from the ward can come and attend this urgent case. That you prioritize well.
There are like 3 sections which you have to go and do. Then you can ask for additional manpower. But in this particular scenario, additional manpower is usually not required. Because when you are going through the other boards, you can ask your ST2 and midwife to take the consent for room number 2. And I myself will do the section. I'll ask my consultant to do inform about room number 5 and prepare the patient for section. Room number 6, until I finish the I'll ask my senior midwife to attend the patient, start her on antibiotics, take investigations, and after the section, I'll go and see the patient myself. Okay?
Or the consultant will be going and seeing. Either can
because overall because overall the sequence I told room number 1, then followed by 5, and then followed by 6. I told in this way.
Yeah. You did it.
Prioritize among the urgent rooms. You have to identify the urgent rooms and prioritize them. Like you have to assign someone. In those urgent rooms, no one will ask you to pick the topmost urgent room as long as you are prioritizing it well. Am I right, Dr. Preeti?
Okay, means it is not necessary to give them the order.
No. You don't have to give the order like first is room number 1, room number 5, room number. No need.
You have to say
what
rooms are urgent and what all are semi-urgent and routine. That would be fine. But you don't miss any of the urgency case. That's all.
You might have done the station very well, and at the end, you might be like out of the exam stress or something. You might have done something wrong. You might have missed the topmost priority case. Like instead of giving us top priority, you might have given us a third priority. So don't confuse yourself. You don't have to pick the topmost priority. This is the number 1. This is the number 2. This is no need. Don't put that much strain. You have to prioritize and assign because you are going to one room, your consultant is going to one room, and by the time you finish the section, midwife is doing the work for you in the chorioamnionitis case. So none of those urgent rooms are left unattended, right? That alone is fine. Dr. Preeti, would you like to add anything?
Yeah, no, you covered most of the points, Dr. Lakshmi. That would be nothing to be added.
Any doubt?
Can I ask you regarding room number 9? It's mentioned awaiting ARM. So who is going to do the ARM?
ARM,
Once we settle everything, we can do controlled ARM. Sorry, we can do ARM. So usually in the labor board, you can say like this: if the patient is waiting for ARM, you have a lot of things to settle in the rest of the rooms, right? So why to do ARM immediately for this patient and add another room? Maybe the patient can stuck up in shoulder dystocia, it becomes an urgent room. So don't go into the details who is going to do the ARM. After settling the urgent rooms, I'll ask my midwife to do the ARM. Got it? Because this is not a priority as long as the CTG is good. If the station they might have complicated is as there is a pathological CTG or something, then you have to initiate ARM. As long as the patient is fine, there is no urgency for ARM in this room number 9. Any other doubts? So always introduce yourself. Keep the introduction as short as possible. Start either room-wise or urgent. Identify what is the situation. Ask the questions, typical questions. Don't ask observations for each and everything. Ask what you want to hear. And if there is any extra information apart from the questions you have asked, obviously the examiner will tell you. But be specific about your questions. Anticipate the risks, measures to decrease the risk, and then prioritize. And the good thing about your presentation was you didn't read out all the information that was given in the task. It was a very good habit, and you don't have to read the information. And in each room, follow this order, which I have told you earlier, so that it will be easy for you. And
most important thing which I learned, Dr. Lakshmi, from you, you involve MDT in each and every case.
Yes, even if it is simplest room,
Like it was not my
everything.
yeah.
See, if the domain is with the communication with the colleague, they will be expecting like means whom has to be involved. So always, whenever the domain, whenever the question is given, always it's better to involve MD